Hello, and welcome to the Osteoarthritis Action Alliance Lunch and Learn webinar for November 18th, 2020. Thank you for joining us this month. Our presenter today is Dr. Charla Johnson. Dr. Johnson has over 32 years experience in the healthcare industry and in nursing, with a majority of her nursing career aimed at the promotion of musculoskeletal care and the advancement of orthopedic nursing in the region, state, and at the national level. Dr. Johnson is board certified in orthopedic nursing. She currently serves as the president-elect on the National Association of Orthopedic Nurses Executive Board. In addition, Dr. Johnson serves on the Louisiana Arthritis Foundation Board, and she is an executive steering committee member for Movement is Life, a stakeholder group aimed at reducing musculoskeletal health disparities in women, African Americans, and Latinos. Outside of her volunteer roles, Dr. Johnson serves as the System Director of Nursing Informatics at Franciscan Missionaries of Our Lady Health System. In this role, Dr. Johnson is responsible for promoting interoperability of the electronic health record and the integration of evidence-based practice into the documentation paths for all clinicians. We're delighted that Dr. Johnson could join us today for a presentation titled How OA Treatment Can Become a Shared Decision. Dr. Johnson, welcome, and I'll let you take it from here.
Thank you, Nick and Katie, for the opportunity to present. I'd like to start off the talk with a reflection, and let's just place ourselves in a moment to think about what would life be like if you had joint pain and if you didn't have a car, or the closest grocery store was more than 5 miles away. Where would you shop? What if there was not enough money for your prescription medications, your therapy, or copay for OA treatment? What if you didn't understand what the provider just told you in your encounter? Or what if you understood everything your provider just told you, but now you're feeling powerless, hopeless, and overwhelmed? What if you lived in a rural or even an urban area and you do not have a specialist, or maybe even a way to get to and from appointments, or go to the gym, or the grocery store, or you do not have a safe place to walk or move? Well, we call these types of issues and barriers social determinants of health. And as a nurse and a member of the healthcare team, I value health equity and have looked for ways to help patients overcome hurdles to their health and health care. In orthopedics, we have treatment pathways that care for patients with OA, but not all discussion treatment options are the same because each person brings with them a social, a physical, an environmental, and an economic picture unique to them. And this is why a personalized and shared decision about OA treatment is so important to advance health equity. Osteoarthritis is the leading cause of pain and disability, and more than half of all adults will develop symptomatic OA of the knee at some point in their life. Approximately 240 million people worldwide with symptomatic OA of the hip and knee that's activity limiting. The CDC estimates 1 in 4 in the US alone. We know that a number of comorbidities and coexisting conditions often occur in patients with OA, increasing people with OA's mortality. At Movement is Life, we have generated a visual to show this vicious cycle of joint pain. And we know that with joint pain and stiffness, the patient begins to limit and self-restrict their mobility. And when people hurt, they move less and sit more. And the lack of physical activity perpetuates the weight gain, which leads to obesity. That excessive joint load causes the increased pressure on the knee joints, which then causes more joint pain. And it's just this vicious cycle. And we believe that the key to breaking the vicious cycle is movement. But to the individuals, our patients, that seems counterintuitive, right? But we know that movement is what keeps the lubrication and that fluid production in the synovial membrane around the joint active and producing. I call it motion is the lotion. But there is the outer band, that green band that you see, that band of social and environmental factors and determinants of health that add a layer of separation from actively following recommended treatments or movement. Access to health care, especially specialty care, our zip code, biases, education, literacy, those all things live in that band. And then the outer band, that blue ring, that public-private policy it adds to the challenge as well. We've seen an increase in disparities with our bundle payment models as the associated risk and penalties lead to what we call cherry picking and lemon dropping. And this model rewards hospitals and providers for delivering care at a lower cost and potentially punishing for providing care to sicker or more at-risk patients. Current healthcare policies place our patients at risk of not receiving the care that's needed. So the aim of Movement is Life is to decrease these musculoskeletal health disparities among women and racial and ethnic minorities by raising awareness of their impact on chronic disease management and quality of life. By promoting the importance of early intervention, we seek to slow musculoskeletal disease progression, reduce disability, and encourage physical activity and daily movement to improve the overall health of the nation. Again, movement is the key. In the previous slide, I shared about the outcomes from joint pain as it relates to obesity and comorbid conditions. The rate of obesity in America is staggering. It's long recognized and fast-growing public health issue with 48% of African Americans, 43% of Hispanic, and 33% of Caucasians affected. Reversing this trend needs to be a national priority. Lifetime risk for symptomatic knee OA is 60.5% among persons who are obese. That's double the risk for those of normal or underweight. Of those stalking statistics, more women than men are impacted. The impact cannot be overstated. Obesity is the major factor of developing type 2 diabetes, and minorities are disproportionately affected. The CDC recommends greater use of evidence-based physical activity and self-management education interventions. Physical activity is the key to reducing comorbidities, yet 45% of African Americans, 43% Hispanics, and 36% of Caucasians are physically inactive. The current levels of physical inactivity are partly due to people being less active during these leisure times, those increase in sedentary behaviors during occupational and recreational activities. There are environmental factors which also can hinder physical activity. This could be related to violence or high density traffic, low air quality and pollution. It could be lacks of parks, sidewalks, sports recreation facilities. And we need to remember that these are the barriers that our patients have to overcome. OA is a degenerative progressive disease of wear and tear, so there's no active cure, no remission. OA detection in early stages is the key, and that's what we promote. As clinical providers, we know that the treatments available can reduce pain and improve function, but many of the treatment options are lifestyle dependent. And we can offer pharmacologic interventions, but comorbid conditions such as hypertension and heart failure, renal function impairment, these complicate those medication selections. And then pharmaceutical therapeutics, well, they're not without association of side effects and adverse events. And because it's not a one size fits all, there's not a magic bullet. And even if you recommended a treatment pathway, does the patient's insurance pay for it? I mean, every person's coverage is different. It's different enough that the individual's out-of-pockets may make it unaffordable, so access becomes an issue. Some coverage requires a certain length of time or number of physical therapy appointments or other treatments to be done prior to additional diagnostics even being ordered. It's a challenge to manage as a provider, but it's also a challenge to manage as an individual. Which is why we need to focus on early intervention because there's a cost to delaying treatments of any kind. The earlier we start the treatments, the more we save as a healthcare system. But should a person's zip code predict the life expectancy or gender influence the quality of treatment they receive? Women and individuals of color suffer more from disabling joint disease than Caucasian men. And when those same individuals, particularly in lower incomes, get lost in the chaos of untreated joint disease and the comorbid conditions that develop with obesity, such as diabetes, hypertension, heart disease, and depression, these patients get chronic pain, disabling conditions which require walking aids, and eventually wheelchairs, and then a shorter life expectancy. And we have disparities. Early intervention is key. And we need to have real discussions with patients using visual aids to help them see themselves as part of the discussion. And these discussions must be intentional. Shared decision making is an approach where clinicians and patients make decisions together using the best available evidence. Patients are encouraged to think about the available screening, the treatments or management options, and the likely benefit and harms of each of those so that they can communicate their preferences and their values and help select the best course of action for them. And that's sometimes where it gets lost. When we talk about the art and science of healthcare, shared decision making is certainly an art, and each patient, I think, represents a unique canvas. Even though healthcare professionals believe they practice shared decision making, I would say the art hasn't been perfected. In ortho, there's little evidence on shared decision making, even in advanced treatments such as knee arthroplasty. Most of the outcomes are arriving at some type of informed decision or informed consent. Shared decision making is not part of our healthcare culture, nor is it part of education that we're provided as providers. It's not part of incentives or reimbursement strategies from CMS or any other payer. But what we do know about shared decision making is that it reduces decisional conflict. It does impact patient self-efficacy on asking questions. It's been shown to reduce hospital readmissions and decrease patient anxiety and healthcare costs. And as part of value-based care, there has been talk about adopting shared decision making as a quality measure, as we know that this can be probably just a carrot approach. The National Quality Forum announced standards for decision aids alongside a report about shared decision making in healthcare, and they see it as a key standard of care. Shared decision making um, respects the patient's autonomy and promotes patient engagement. It becomes more widely recognized as a personalized approach with potential to improve outcomes and patient satisfaction. We know that non-operative management of mild to moderate knee OA is effective in reducing symptoms and may delay disease progression. But we also know that increased physical activity and weight loss, when indicated, are the hallmarks of non-operative self-care. And engaging patients to adopt such behaviors can be challenging and may be improved to the use of shared decision making. Patient-centered care is emerging as a model of this quality healthcare, and it promotes effective communication between the provider and the patient. And in the literature, there's the Picker's principles of patient-centered care, and there's 8 principles, but I focus on the first. Respect for patients' values, preferences, and express needs. You know, I think when we're looking at patient-centered care, I really think we do touch on a lot of these in our spaces, but really tuning into the patient's values, preferences, and express needs, really looking into their emotional support and how we can alleviate their fear and anxiety and providing them with information, communication, education are really the things that we need to hone in on, especially on with shared decision making. In clinical orthopedics and in primary care, there are a number of barriers to the implementation of shared decision making in practice. The adoption of decision aids is difficult. You know, bringing in new things, it means you have to be educated on them and you train your team. There's a belief that shared decision making is always occurring. So why, if I'm already doing it, why do I need to do something different? The increase in time spent with the patient, and we know that time is such a valuable resource, and that if I do something extra, I'm not going to have enough time to do the next. And then there's those ingrained clinical procedures, right? It's just the way we've always done things. I'm not going to interrupt my workflow or processes. And these are actual barriers that are in the literature. But we do know decision aids can provide information about evidence-based treatment options to enhance that discussion, enhance informed decisions, shared decisions, and the consent process. We also know that communication that's free from bias, that's transparent, and comprehensive, that occurs between a trusted provider and the patient, it's irreplaceable. It's like the commercial, right? It's priceless. When The Movement is Life shared decision-making tool was developed, and I'll share it with you in a moment. It was piloted across the country at 8 centers. The project was supported and underwritten by Zimmer Biomet. It focused on the early experiences with African Americans and Hispanic women. The tool uses treatment pathways, um, looking at both patients' self-report of pain, activity level, and some personal biodemographics. When that tool was used in the 1-month follow-up, on patients' self-reported levels of physical activity in the intervention group where the tool was used, they had significantly improved physical activity. Both groups had a high likeliness to recommend the provider to the friend or family. And the qualitative feedback that we received from the provider or the clinics, these 8 clinics across, they had high satisfaction with the use of the tool. So they shared that the tool was easy to use, it was friendly to use, it navigated well in a conversation. The aim of the tool is on early moderate stage OA. Although all stages of OA are identified in the tool. The focus of the treatment paths on non-operative and conservative treatment, although again, later stage treatment options for total joint arthroplasty are OA options. So you can see here the conservative and non-operative therapy options are weight loss, activity modification, so increasing our physical activity. Talk about using braces, glucosamine and chondroitin, using medications, over-the-counter medications, and then using injections. So how is the tool used in practice? Well, a patient with knee pain is seeking treatment in primary care or orthopedic care settings ideally. And that's what we hope is happening. We know that patients likely may seek in urgent care or even emergency situation, but ideally we want them to come to our primary care and our orthopedic care settings. And when a patient seeks treatment, the provider determines the treatment options based on the physical exam and assessment, the patient's history, the diagnostic studies. And we know that communication is a critical skill during this encounter. This allows the emotional dimension of the patient's experience to be explored, and that's important in the shared decision-making conversation. And we talk about the positive use of decision aids with educating and informing the patient. The provider will need to actively listen to the patient's concerns, their goals, questions, and based on the findings, the provider will select 2 treatment options from the tool. The tool allows you, there's 3 options that are there. There's always a default option of not doing anything. And then there's 2 treatment options that the provider will choose based on those physical exam and diagnostic x-rays. Because these conversations, the shared decision-making conversations, can become complex, time becomes a valuable and limited resource. Efficiency can be achieved in shared decision-making by using the decision aid or the shared decision-making tool. The provider also can choose to delegate the shared decision-making conversation to another member on the healthcare team. And this could be the nurse or a physical therapist or a medical assistant, someone else on the team who's been trained to use the tool and have the conversation. Or the conversation can be deferred to another time in a different format. In the Movement is Life shared decision-making tool, it's interactive, it's personalized, it uses and generates the statistically likely outcome for patients with similar demographic characteristics as the patient. The tool leverages an underlying Markov model, which is a financial model, and presents likely pain, activity levels, and lost productivity at 3 future time points. So at 1, 3, and 6 years, the patient is able to see themselves in a future state. By comparing the patient's likely progression depending on the treatment choices, when they lose weight and increase activity, for example, or use physical therapy or NSAIDs or joint injections compared to doing nothing, the patient has an illustration of their future state. The shared decision-making OA tool has 8 different pathways, and again, it's based on the disease progression. And the tool, again, will compare a non-treatment pathway of the patient doing nothing with the 2 treatment pathways selected by the provider. Now, the provider may identify a primary or preferred treatment option and a secondary alternative option, but if there's only one option in the tool, the provider would choose that one twice. You will also notice that the pathway includes lifestyle management, which is weight loss and exercise, bracing, nutritional supplements, therapy, pain medications, NSAIDs, anti-inflammatories, corticosteroids, hyaluronic acid injections, knee scopes, and an operative path for total joint. And again, no treatment or doing nothing is an option as part of the path. The share approach can be used as well because this helps, again, help us categorize how we're going to have the discussion. So we would seek the patient's participation, help the patient explore the treatment options, assess the patient's preferences and values, work with the patient to reach a decision, and then evaluate the patient's decision. In the tool, it's a one-time registration. It's so simple to use. It's available to use and it's free. There is a one-time registration using the URL link, and the link becomes individualized. There's terms and conditions just like you would with any other registration, but when you do the terms and conditions, it also brings you to a place that provides tutorials and PDF materials on the tool itself and the training. Um, Again, there's nothing you have to do from your health system or your computer. There's no system-wide terms that are of use. There's no back-end work in your medical record. There's no need to remember a password. It's linked to you in your email. There's no delay for the user. As soon as you register, you're able to use the tool. It has been now our tool integrated with QC Health in several organizations' EMRs. This is an example of the tool. So when I click on the URL and it pulls it up for me, it tells me my clinical site and it will populate what patient number you're on. So it continues to calculate. So this is an input tool. So you can see here that a member of your healthcare team could enter the input information, and the tool uses the patient's personal health information and their self-reported pain and activity level to demonstrate the effectiveness of the treatment choices and adherence to treatment on future knee pain, activity level, and financial productivity. And again, the tool also includes the impact of the patient's inaction of doing nothing. So you can see that here we would enter the 2 treatment options. Down here, you'll see there's a drop-down box. These are the choices that you would be able to select. You would choose 2. The third automatically defaults as doing nothing. You select the gender, age, height, and weight. It populates the BMI once you put in the height and weight. You look at the comorbidities and do they have hypertension or diabetes? You select race and ethnicity. Their living arrangements is important from a support system independence, and then their marital status. Here on this page, you can see that it takes into account the highest achieved education level. So again, you're collecting this information from the patient. Your insurance types and their self-reported pain and activity. And again, note the scales are on a 1 to 10 Likert scale. I always say 1 to 10 with 10 with pain, 10 being the worst, like I'd rather be dead than have that kind of pain. Activity is again 1 to 10 with the greatest limitation of disability you can see identified with the wheelchair, followed by the walker, cane, and then assistance. The tool is also available in English and in Spanish. So here I've already inputted information for a 52-year-old African-American female who has some college, private insurance, married, and no comorbidities. And this is the output. So you can see here, it creates a PDF for the patient. I can share this with the patient and I can look at it. I mean, look at the impact of losing weight. These are the discussions we have with the patient. The impact of losing weight, increasing your level of physical activity, and using over-the-counter medications on their knee pain. You can see how it goes down. The tool suggests that if the patient followed this pathway, the patient's knee pain would improve from today's level of 3 to practically no pain in year 1, and in year 3, a level 1 at year 6. Likewise, their function will improve to near normal functions for 3 years, and then by 6 years be back to level 2. So as you can see, the pathway of physical therapy, the injections, prescription medications will also help the patient's knee pain and function. And although in this treatment pathway, they could have some out-of-pocket expenses for the physical therapy and injections, they're uncomfortable. So they can look at their decision, but you can see when you doing nothing is just going to cause pain, but it's this visual that shows them that they need to do something. It becomes a motivator for them. So let's look at what happens again if the patient does nothing. So you can see that the knee pain will get worse and their function will decline, and that is not a good future. And at the bottom of the tool, you see the impact of these 3 options on their personal productivity and estimate loss of income. Well, doing nothing not only gives the patient the most pain and functional limitations, but it also gives them the highest loss of income. Again, you can see when the patient leaves the office having a shared decision-making conversation that they really realize that to not do anything, there's a personal cost. So their pain and their activity are impacted, putting them in more pain and could make them less active. I did a second patient type here. It's an output for this patient is 52-year-old African-American female with no college, has Medicaid, single alone, hypertension, and diabetes. And the outcomes are different just based on that. Again, they used the Truven database and a Markov model to outline these projections. And those things matter. The type of insurance, whether they had a support system, live alone, and whether they had comorbidities, it makes a difference. You can see again, one of the great things about the PDF, the tool, is that none of this information that you're inputting in the tool saves anywhere. So you don't have to worry about de-identified information. There's nothing, no kind of other share or use because it doesn't hold the data. So when you create the output tool, you could save the PDF. You can print to save it for your medical record, and you can print to share it with the patient and provide them with a copy. The tool itself provides the support for the discussion. It's outlined by step. We take them through their knee pain, their activity, and their loss. It really does, evidence indicates that biases are likely to influence our treatment decisions and diagnosis about what we offer to patients, but this eliminates that. Unconscious bias may influence how a person's information is processed, and it creates unintended disparities in patient care. And again, this eliminates that. It provides a quasi-script for explaining, again, the outcome, a consistent communication pathway, and it can reduce disparities by addressing unconscious bias. Decisional conflict may be reduced by using the tool, as the framework provides a comparative best practice treatment pathways centered on the patient's disease progression, their personal health information, and their self-report of pain and activity, and it produces a visual representation of the predictive outcomes based on similar patients. So we've taken that bias away. The focus groups, again, have shown that the patients appreciate the overview of the treatment options available to them for the NEOA when they were looked at developing this tool. And as a provider, you can be a catalyst. We can be a catalyst for change by incorporating this tool into practice workflows. The tool is designed where the shared decision-making conversation can be delegated to another member of the team. As a provider, selecting the treatment options based on the patient's stage of OA is an important factor to let the patient become involved in the process. How difficult and disheartening is it to have that repetitive conversation with the patient about weight loss and activity, right? laborious, it's difficult, it's frustrating. But then how discouraging it must feel to be the patient to hear it over and over about weight loss. We know this is not an easy conversation to have, and it's not an easy thing to accomplish. Promoting healthy weight as well as increasing activity as a treatment option should be approached always with using respect and empathy. For many, achieving and maintaining a healthy weight is challenging, right? Personally, I think I've been on a perpetual diet since I was 13. I'm sure many of you feel this way. I mean, it's a constant thing that we have to do to take care of ourselves, but it's a uphill battle for some. When a patient is able to see themselves in a future state, to see that their consequences of their actions is so powerful. And when the provider can connect with the patient's why, with their challenges and their motivating reasons, a shared decision can be reached. We can help the patient set realistic and achievable goals to decrease the weight-bearing effect on the knee joint. We know that clinically important benefits are gained with increased weight loss, even if 5% or greater for OA symptom management. And we know that there's benefits that are further enhanced when we also concurrently use exercise. Helping the patient visualize themselves in a future state can be a catalyst to the behavior change that's needed for self-management. It can also create the partnership that you as a provider is longing to have with the patient. So at Movement is Life, we would love to be able to demo this with your office practices, with your healthcare organizations. Katie will be sending out in the follow-up recording how to request that demonstration. We would love to be able to work with you and help your team use this tool in practice. We believe this is the way that we can really help reduce disparities. I want to thank you all for allowing me the time to be able to talk and share this information.
Thank you, Dr. Johnson, for that fantastic presentation. We have time for a couple of questions, and a couple have already been entered into the chat box, but you're more than welcome to type any questions you have in the chat box as well. Also, in a few minutes, you'll see a poll pop up on your screen with some survey questions. Please answer these questions before you leave the webinar. All right, Dr. Johnson, scrolling through the questions. The first one we have is regarding sleep. And the question was, interesting that rheumatology clinics are not a source for patient treatment in that slide. Have you any thoughts on this?
Nick, can you say that again?
Sure, it is a question regarding slide number 16.
Okay.
And it says, interesting that rheumatology clinics are not a source for patient treatment. Have you any thoughts on this?
Oh, as for where they would seek treatment? Well, absolutely. If a patient is seeking treatment at the rheumatologist office for their OA, the tool is designed specifically for OA. So we felt like patients with knee pain related to OA would be primarily driven to the primary care in orthopedics. But this tool can be used in any setting as it relates to knee pain.
Okay. Scrolling through the next questions. Were the treatment pathways based on published clinical guidelines? If so, were the guidelines from the American Academy of Orthopaedic Surgeons? Because there's some differences in the pathways from the American College of Rheumatology OA guidelines.
Correct. So when the tool was developed, they used the treatment pathways within from the content experts from those 8 centers, and used from the treatment sources that were part of the billing database that was in the Truven database.
And it appears we have one more question for you today. How can you ensure that the provider is practicing that shared decision making?
Well, I don't know that you can ensure it. I think that we aspire to it, right? using the tool, I think if you were to incorporate it into practice, one way to assure it would be that the tool is saved into the patient's medical record and there's documentation that the tool was used and a shared decision-making conversation was had, which I think is very doable with the questions that we already have in our ambulatory settings in our office clinics documentation pathways. So I think that's one way that an office practice could assure it. I think we have to talk about it. I think we have to have expectations about it. I think, again, we look within our practices, we look at the barriers and we don't always look at the solutions. So I would challenge and hope that we have a champion on this call that would like to use it in practice and have figured out ways and to overcome those barriers of time. You know, there's some really creative ways that some practices are using it right now. They're thinking about using it not as an individual, but where they have a group of patients and they have the treatment pathways for each patient. The patient is given their tool. They set up a virtual call and the patients, there's a nurse navigator on the line, and she goes through the tool. So the patient on the other end of their call is seeing their information, and the nurse is walking a group of patients through how the tool, what does it mean for them so that they can visually see it. That is a creative way to kind of overcome the barrier of time within the office space. But I think there's more solutions out there.
Okay. Thank you, everyone. That concludes today's presentation. Please join us next month on December 16th when our Lunch and Learn presenter will be Lisa Irk, who will discuss leveraging partnerships to develop a sustainable approach to increasing adoption of arthritis-appropriate evidence-based interventions with employers. Thank you.